Good evening, everyone. Today we will discuss about the COVID-19 management in the cardiac patients. As we all know, SARS-CoV-2 causing coronavirus disease COVID-19 reached the pandemic levels in the March 2020 and has caused repeated waves of outbreaks across the globe. COVID-19 shares many manifestations of systemic disease and has major implications for the cardiovascular systems. Now the many variants comes since last 2 years. The initial variants was the wild type of variants, which that was the first spike. The second spike was due to Delta waves, and now at present the third wave is going on, and it's due to Omicron variant. The variant Omicron variant was first reported in by WHO in South Africa in November 2021 and designated as variant of concern and named after as Omicron in on 26 November 21. Now, the impact of the cardiovascular comorbidities on the COVID-19's outcome. The CV comorbidity are more common in the patient with COVID-19. Presence of CVD is associated with the severe COVID-19 and having a higher morbidity and mortality. CV risk factor are linked with the severe COVID-19 infection and higher mortality. Now, what is the basic cardiovascular involvement in the COVID-19 infection? As we all know, SARS-CoV-19 viral invasion, which causes inflammatory and cytokine storm, which leads to myocardial damage. The viral invasion leads to also microvascular thrombi, hypercoagulability, microvascular dysfunction, endothelial dysfunction, plaque instability, plaque rupture. This all leads to acute coronary syndrome, pulmonary embolism. Myocardial damage leads to myocarditis, heart failure, and various type of arrhythmia because of myocarditis, COVID-19 infection, and various drugs used in the management of the COVID-19. Now I want to share two recent article published in the NEGM, one which is on molnupiravir for the oral treatment of the COVID-19 OPD patients, which shows the early treatment with the molnupiravir reduce the risk of hospitalization and death in COVID-19 infection, particularly in Omicron variant. Second article is about remdesivir, early remdesivir, 3-day course of remdesivir to prevent progression to severe COVID-19 infection in OPD-based patient. Non-hospitalized patient who were at the high risk for COVID-19 progression, 3-day course of remdesivir had an acceptable safety profile and resulted in 87% reduction in the hospitalization as compared to placebo. Now, the recent guidelines regarding the management of the COVID-19 in the setting of Omicron variant, the Mount Sinai Health System Adult Treatment Guidelines. We'll discuss about something about Mount Sinai guidelines, which suggest if the patient is asymptomatic, only supportive care is the management of therapy in Omicron variant. Symptomatic patient not requiring oxygen supplementation and saturation is more than 94 on the room air. The treatment option so they suggested are the monoclonal antibody like sotrovimab, which is not available in the India, and antiviral drugs like molnupiravir, remdesivir, and Paxlovid. Paxlovid is also not available in India in the high risk group who are symptomatic and at room air situation is normal. In hospitalized requiring low flow nasal cannula, 4-liter oxygen, and SpO2 is less than 94 in the room air, the treatment option they suggested having SARS-CoV specific antibody therapy, dexamethasone, and remdesivir. If in spite of remdesivir and steroid deterioration in spite of 24-hour therapy with steroid, considered for baricitinib and tocilizumab. Now comes to our patient. Our patient is 60-year-old male, post-CABG status, presented with COVID-19 with normal vitals with elevated inflammatory marker like CRP and D dimer. He is fully vaccinated, but has been 9 months since the last shot. What will be approach to this patient of COVID-19 and having CV morbidity? Now, the Basic treatment goes through to assess the severity of illness with clinical examination and other inflammatory marker, treat according to the severity of the disease, and rule out any cardiac complication precipitated by COVID like arrhythmia, DVT, and LVF. Uh, Now, what Indian guidelines suggest? AIMS ICMR COVID-19 guidelines, which revised on the 14th of January 2022. Now, all the cases are of COVID in India is Omicron variant, and we should categorize the COVID-19 illness into three categories: mild disease, moderate disease, and severe disease. Mild disease only home isolation and supportive care is the treatment of choice. In moderate disease, like saturation is less than 90, less than 93 on room air and respiratory rate more than 24 hours and symptoms of breathlessness. This comes to moderate disease and should be admitted in the ward. And the severe disease respiratory rate more than 30 per minute and room air saturation is 90% admitted in the ICU. Now, if we consider in our case, if post-CABG case, 60-year male with raised CRP and D-dimer, if patient is asymptomatic, no any specific treatment relevant to COVID is required. Only home isolation and supportive care like paracetamol and decongestive treatment is the treatment of the choice. If our patient is symptomatic, then this patient comes into high risk category and symptomatic like high grade fever, persistent body ache, fatigue, and we should consider for early antiviral therapy in initial days of illness, like available molnupiravir or remdesivir. Remdesivir is the first choice to prevent progression because, as we discussed already in NEGM trials, it shows 90%, almost 87 to 90% risk reduction into progression to severe disease. Uh, if patient develop progression to disease and patient develop hypoxia, situation is less than 94%, then we should consider for steroid methylprednisolone or dexamethasone. Dexamethasone, usually we give a 6 mg IV OD dose and monitor inflammatory marker, monitor SpO2 level, prone positioning, and other psychosocial support therapy, physiotherapy, lung rehabilitation. We should be supportive treatment in these cases. And if in spite of steroid and remdesivir, the patient is still deteriorating and patient require high flow nasal cannula or NRBM and oxygen requirement is gradually increasing, we should consider for tocilizumab or bezisterimab like Janus kinase inhibitor should consider in this patient. All other supportive treatment like antibiotics in case of infection, bacterial infection, IV fluid management, psychosocial support, DVT prophylaxis. Usually, when the patient having oxygen requirement, we should consider for prophylactic dose of low molecular weight heparin or conventional heparin to prevent permanent thromboembolism. Now, how we monitor these cases? Like we should do serial chest X-ray or CRP dimer monitoring level to show the result of to show the response of the steroids and tocilizumab. Um, that's it. Thank you.